Stroke and complete heart block are two important problems after the procedure.
Correct.
Stroke, you told you prevent or reduce stroke by complete neurological evaluation and then protection device. So what do you do, or what are your protocols to prevent heart block after procedure? What specific measures you take to reduce the incidence of heart block?
Now, very important. So the most important thing for the heart block is the substrate, in the sense that the anatomy of the non-coronary cusp and where the AV node and the His bundle lies, this is what causes the heart block. So what we try to do, compared to other people, is to put the valve as high as possible so that we do not impinge on the conduction system. The most important part also we learned is that we do not pre-dilate the valve. So if you use a balloon to pre-dilate the valve, you have two injuries to the conduction system with the balloon, and then whatever you use the valve. And the valve, when we put it, either the balloon or the self-expanding valve, again, sizing is the key. So not too oversized and not too undersized, because very oversized valve obviously cause more conduction abnormalities. So one good message to take home is that imaging, learning imaging, dedicated part to saying that procedure is important, but procedure is technically not that challenging. It is the planning that is very, very challenging.
So actually, the paper that we just published in Trends in Cardiovascular Medicine describes exactly that approach. And there is a paper that was published in 2015 referred to as phenotyping of patients with heart failure with preserved ejection fraction. So I personally have a lot of difficulty with the nomenclature because it's not one disease. Heart failure with preserved ejection fraction, if you look at a patient with hypertrophic cardiomyopathy versus a 85-year-old woman with hypertension, they're very different diseases. Yet the guidelines committees have chosen to put all of these into one category. And the trial that I mentioned, which is reduced lap HF2, if you look at the inclusion and exclusion criteria, there's over 40 criteria. So this clinical trial, I believe, is trying very carefully to eliminate patients with valve disease, with significant systolic hypertension, with infiltrative cardiomyopathy, definitely hypertrophic cardiomyopathy, to get a very homogeneous group of patients, with the common denominator being that their ejection fraction is over 50%, and if you exercise these patients, their wedge pressure will go up. So I think that's the common denominator, but many of these clinical trials have probably failed because of very heterogeneous groups of patients that were put into the clinical trials.